Welcome everyone to our final presentation of today's Understanding WM workshop. This is the very first day of the 2021 IWMF Virtual Educational Forum, and it's been a very exciting day. I'm Eileen Sullivan, WM patient and IWMF support group leader for Massachusetts and nearby New England. I was diagnosed way back in 1995 and learned very quickly that WM is not a disease that's simple to understand or pronounce. When I eventually needed treatment in 2003, we knew very little about the genomics of Waldenstrom's. But thanks to the unraveling of the Human Genome Project, which coincidentally happened to be finished in 2003, we now have had many decades of wonderful research into the understanding of the mutations and all the craziness of Waldenstrom's, macroglobulinemia, or chronic lymphoplasmacytic lymphoma. So you have to learn to be able to pronounce crazy words too. Over the past few years, I have gradually built up a beginner's understanding of genomics by listening to some of our amazing researchers. I learn more each time, and I look forward to doing that again this afternoon. Our presenter this afternoon, Dr. Sikander Ailawadhi, sees WM patients at the Mayo Clinic in Jacksonville, Florida. Today, he's going to explain the basic genetic concepts behind the mutations that are so important to the understanding and treatment of Waldenstrom's macroglobulinemia. At the conclusion of the lecture, Dr. Ailawadhi will have time to answer some pre-submitted questions from the audience. Welcome, Dr. Ailawadhi, and I turn it over to you.
Thanks a lot, Eileen, and thanks to the IWMF to give me this opportunity to speak with the group today. So I want to agree with what Eileen mentioned about not being able to pronounce the difficult words, but Eileen, you did a great job pronouncing my name, which by no means is an easy one either. As I said, once again, thanks a lot for this opportunity. I'm one of the hematologists from the Mayo Clinic in Jacksonville. I've been focusing on Waldenstrom for several years, and I'm happy to say that now we have a very robust clinical and research program for Waldenstrom treatment in Mayo throughout, but I would say also particularly in Mayo Jacksonville. So today's discussion is about the genomics and science of Waldenstrom. There's a lot of complex information to share or to think about or at the cutting edge of research. And it's with that information, which is driven from the biology of the Waldenstrom disease, that we are able to push the envelope to move the field forward and hopefully develop better, more meaningful treatment options. My job today is not just to throw all these terms at you, but to try and hopefully make some sense out of the information out there, and not just facts, information, but also how does that have a clinical implication in your case, okay? So I'm gonna bring up my screen with my presentation, and as Eileen mentioned, we will be focusing on the presentation, but after this, hopefully we will have sufficient time for questions and answers. So, Waldenstrom's, as is not news to this particular audience today, is a rare plasma cell cancer with roughly about 1,400 to 1,500 new cases diagnosed in the US each year. Every Waldenstrom, we believe, has a precursor condition which precedes it called IgM-MGUS, or IgM monoclonal gammopathy of undetermined significance. Hence the words, large words, long words, names. And that confers, just the presence of IgM-MGUS confers a significantly higher relative risk of developing Waldenstrom as compared to someone who may not have developed or known to have IgM-MGUS. Now, Waldenstrom is a unique diagnosis because it is in the B cell lymphoid lineage. And within the B cell lymphoid lineage, a particular time point when these B cells transition from lymphocytes to plasma cells, and I will actually touch upon this because that is very important to the understanding of how Waldenstrom presents and what we may be able to do for treatments. So that lineage, the lymphoid lineage, B lymphocytic lineage, when the cells transition from a lymphocyte to a plasma cell, if it goes haywire at that point, that's where lymphoplasmacytic lymphoma or Waldenstrom's comes up from. And the diagnosis of Waldenstrom is made by an increased level of IgM protein in the serum and the presence or aggregation of these lymphoplasmacytic cells inside the bone marrow or other organs. As I mentioned, it is a unique lymphoid malignancy. This monoclonal protein or abnormal protein is essential for the diagnosis of Waldenstrom's macroglobulinemia. And we also know that it is these abnormal cells in the bone marrow or lymph tissue or liver, spleen, etc., as well as the IgM protein, these can result in the symptoms and signs of the disease. We will be talking about the MYD88 or MYD88 or however you may want to pronounce this particular mutation, MYD88 L265P, which is a mutation present in more than 85%, nearly 90% of all Waldenstrom cases. It helps to actually, in nowadays, make the diagnosis. And also, it may mediate in the response to medications like ibrutinib. We also have something called the CXCR4 mutation. We'll be talking about its implications also. Okay. So when we make the diagnosis, the bone marrow is typically infiltrated with small lymphocytes, small plasmacytoid cells, and plasma cells. So an aggregate of different kinds of these abnormal cells that can be present. As I said, I'll clarify in a bit how some individuals, some patients may have a more lymphoma-like phenotype or lymphoma-like look in their Waldenstrom. The others may have a myeloma-like or a plasma cell-like physiology of their Waldenstrom, etc. These cells, these abnormal cells in the marrow are typically have these, so all of our cells, these precursor hematopoietic cells or blood-producing cells, they have these surface markers like the CD19. CD stands for cluster differentiation. So CD19, CD20, etc. So typically in the LPL or Waldenstrom cells, these abnormal cancer cells in the marrow, CD19 is a marker present, CD20 is present, and surface IgM is present. So if somebody takes a biopsy from the bone marrow and stains them for CD19, CD20, surface IgM, those would be typically positive. Additionally, a CD5, CD10, CD23 can sometimes be expressed. But in Waldenstrom, as you will realize, the exact lineage point of the cell that became haywire or became cancerous will determine what all these markers would be. And the patients typically have to have an IgM monoclonal protein of any concentration. Unlike, let's say, in a sister disease called multiple myeloma, we want the patient to have a certain quantity of the abnormal protein. In Waldenstrom, if the diagnostic criteria are otherwise met, the mere presence of the abnormal protein is good enough. Okay, so this is where I was talking about the lineage, this flow chart, which talks about how the blood-forming cells are present in the bone marrow and how they differentiate. So we have blood-forming stem cells, which differentiate into either myeloid or lymphoid. The myeloid do their own stuff, but the lymphoid series, you can imagine that if at the level of a lymphoid stem cell or lymphoid blast, if a cancer develops, it's acute lymphoblastic leukemia. But as the lymphoid cells mature, they become lymphocytes. They can become different kinds of lymphocytes, B, T, or NK cells. There are a set of NK diseases, there are a set of T lymphocyte diseases, and a series of B lymphocyte diseases. And then these B lymphocytes can mature into plasma cells. So when we talk about Waldenstrom, at that point of transition between a mature B lymphocyte to the plasma cell, that's where the B cell non-Hodgkin lymphoma, which Waldenstrom is also a subtype of a non-Hodgkin lymphoma, if at the point of that transition from B lymphocyte to plasma cell, the cell becomes cancerous, non-Hodgkin lymphoma, including Waldenstrom, can happen. So another way of looking at it is, as I mentioned, there's the stem cell, pro-B, pre-B, naive, and then they mature, go to the lymph node, different parts of the lymph node. Depending on where these lymphocytes are in different parts of the lymph node will give rise to a certain different kind of non-Hodgkin lymphoma. So if there are cells in the marginal zone of the lymph node that are getting cancerous, it's a marginal zone lymphoma. It's written as a dark and a light zone. Frankly, there is a more technical term, but what you can imagine is there is a mantle zone, which will give rise to the mantle cell lymphoma. But similarly, if within the crux of the lymph node, these mature B lymphocytes on their way of transitioning to plasma cell, if that is during that transition the cancer happens, it is lymphoplasmacytic lymphoma. You may feel that I'm repeating this thing again and again, but in my mind, this is an extremely important point to understand about the science or genomics of Waldenstrom, because this helps understand why Waldenstrom behaves clinically the way it behaves and why some Waldenstrom patients may behave differently from others. Okay, so I mentioned there are the B lymphocytes, which have these markers, CD19, CD28, and typically CD38 is negative. Then there are the plasma cells, which have no CD19, no CD20, but CD38 is present. And when we talk about lymphoplasmacytic cells, they are 19 and 20 positive. So you can imagine they have retained the B lymphocyte CD19, 20 markers. And in some cases, they may actually also gain the CD38 marker, which is the plasma cell end of the spectrum. Hence, some Waldenstrom, some abnormal lymphoplasmacytic cells will produce a lot of the IgM protein, leading to very high IgM numbers, the hyperviscosity we talk about, where we talk about plasmapheresis, et cetera, et cetera. And then there are other lymphoplasmacytic lymphoma patients who do not have that much of an IgM component, but have large tumors like lymphomas, like lymph node masses, liver, spleen enlargement, et cetera. When we look at the genomics of Waldenstrom, as I mentioned that a classic B cell malignancy is, for example, what's called chronic lymphocytic leukemia. Chronic lymphocytic leukemia is the cancer of mature B lymphocyte. The other end of the spectrum is a cancer of the mature plasma cell, which is multiple myeloma. Waldenstrom, I've been saying, is somewhere in the middle. But when the gene expression profile, or this is isolating the DNA and looking at the structure of all the genes in the cancer cell, when that is studied, we know that actually the Waldenstrom genetic signature is a little bit closer to the chronic lymphocytic leukemia rather than the multiple myeloma. So there is more of that lymphoplasmacytic rather than the plasmacytic component genetically in Waldenstrom. I mentioned the MYD88 and CXCR4. Why are these important? The MYD88, or the myeloid differentiation primary response gene 88, hence going back to Eileen's point of long terms, lots of words, mouthfuls. But MYD88 gene, when this is overexpressed anywhere, it mediates what is called the NF-kappa B and the JAK-STAT pathway. What these pathways do, these are pro-survival signals. When the MYD88 gene is overexpressed, these NF-kappa B pathway and the JAK-STAT pathway is activated. It gives out signals to the cells to proliferate, to grow, and to survive, and not to die in a programmed fashion. As I mentioned earlier, MYD88 is overexpressed in about 90% of Waldenstrom patients. And in fact, there is a school of thought which says that if MYD88 is negative, then the behavior of that diagnosis, that entity, is more like a run-of-the-mill lymphoma than a classic Waldenstrom. And you will also realize that later on we'll talk about that the drugs that we have, they act differently if the MYD88 is positive or negative. So as I mentioned, MYD88 positivity seen in majority of the Waldenstrom patients, and some believe that if MYD88 is negative, that the behavior of that diagnosis may be very different. And then CXCR4 is expressed in high levels by Waldenstrom cells also quite frequently. CXCR4 is another gene which mediates the interaction of Waldenstrom cells with its microenvironment, wherever it is, whether it's the bone marrow or it's the lymph node, etc. And when CXCR4 is activated or is overexpressed, there is activation of downstream, again, cell survival pathways. So this PI3 kinase, mTOR, AKT, these are different cell pathways where if CXCR4 is increased or is overexpressed, the PI3 kinase, mTOR, and AKT pathways are triggered on by the cell, and the cell tends to survive longer, the cell tends to evade death, etc. Okay, so this is some data showing, actually going to make sure that I'm able to bring up something on my screen a little bit better. Okay, this is data showing that the MYD88 by the MYD88 protein to be seen in Waldenstrom and in other overlapping entities. And what you see over here is that at the bottom of the, this is something called the violin plot. And a lot of these diagnoses of a similar etiology or a similar cell lineage, Hodgkin disease, IgG MGUS, IgM MGUS, CLL or chronic lymphocytic leukemia, multiple myeloma, marginal zone lymphoma, and Waldenstrom. When the MYD88 expression has been compared in these, it is clearly seen that this MYD88 can help differentiate Waldenstrom and, in some cases, IgM MGUS from a lot of the other diagnoses in this vicinity. Why is this important? So when I was training and doing my fellowship, we were constantly reminded by the lymphoma group, by the Waldenstrom leads that, hey, you should think of questions showing up on your boards where they'll give you all these surface markers, the CD19 and 5 and 10 and 20 and 23 and this, that, the other, and they would like you to decipher that and try to differentiate between CLL and marginal and Waldenstrom and PLL and follicular lymphoma and everything. But now life is simpler because now we know that if MYD88 is present, well, we're not dealing with CLL or marginal or this or that. We're dealing with Waldenstrom, or we are dealing with maybe in some cases IgM MGUS. So if a patient has this MYD88 positive, this MYD88 gene is overexpressed, then we know that we're dealing with IgM MGUS, Waldenstrom, smoldering Waldenstrom, etc., but in that spectrum. So this helps differentiate. As I mentioned, MYD88 presence or overexpression is associated with these IRAK4 and NF-kappa B pathway. These are all pro-survival signals. But you will also note right next to MYD88, there's this yellow box which is talking about BTK. And BTK pathway also becomes important downstream of MYD88. So if somebody has MYD88 overexpression, that particular cell is going to depend on the BTK or Bruton tyrosine kinase pathway as a dependent modality for its growth. Now, this is an important placeholder to keep in mind because down the road when we talk about treatments, we will realize that this has been exploited in treatment for Waldenstrom because BTK inhibitors tend to work very well in patients who have this MYD88 expression, aka majority of the Waldenstrom patients. Okay, so hence, as I've pointed out over here, this downstream effect on the BTK pathway, downstream of MYD88, is the reason that BTK inhibitors are able to come in and show their benefit. Okay, there are So whether they affect exactly at the BTK level or a little upstream, that different molecules can be different. Okay. The CXCR4 mutation or WHIM-like CXCR4 mutations in Waldenstrom, again, there are various mutations that can be seen in that area, but the most common one is seen this S338X, where there can be a substitute of one small protein molecule by a different protein molecule. And as I mentioned, the CXCR mutation helps the Waldenstrom cell. And actually, the CXCR mutation is seen in a lot of different cancers. This is not typical of Waldenstrom. Unlike the MYD88, which we are seeing is typical of Waldenstrom, CXCR4 can be seen in a lot of different cancers. And CXCR4 pathway is how the cancer cell, whatever the cancer may be, it sort of interacts with its own environment. Patients who have an overexpression of CXCR tend to have those cancer cells proliferate much easier. They give rise to, as I mentioned, those downstream PI3 kinase, mTOR pathway, and AKT pathway, which will help that cancer cell survive, evade death, or evade the body's immune system, and hence proliferate. And I think I've already touched upon that CXCR4 receptor, the CXCR4 mutation is seen in about 40% of Waldenstrom patients. And this is just how the cancer cell interacts with its environment and can give rise to drug resistance. So CXCR4 mutation can be associated with resistance to certain drugs. Okay. This is just giving you an example that a few years ago, literally just about 3 to 4 years ago, is when our understanding of these mutations and how they can affect our treatment choices started to come upon. This is looking at a study of data from bendamustine and rituximab treatment, where patients who were diagnosed with Waldenstrom were treated. But the French group, what they did was they separated out the patients based on their MYD88 status and CXCR4 status. And what they were able to show was that the outcomes of patients would depend on whether they were CXCR4 wild type or mutated, whether they were MYD88 wild type or mutated, etc. And then since then, that same concept has been applied to, for example, our newer drugs like ibrutinib. And what we are noticing that same concept holds true. And this data over here is showing that when we talk about MYD88 mutated and CXCR4 wild type, meaning the CXCR4 is not mutated. So when we're talking MYD88 mutated, majority of the Waldenstrom, CXCR4 wild type, which is about 60 to 70% of Waldenstrom, the response rates were much higher and deeper. Major response rate, very good partial response rate. On the other hand, when we had MYD88 mutated, most of Waldenstrom, and CXCR4 was also mutated, the response rates were lower and the depth of response was much lower, 68 and 9%. And if both the MYD88 and CXCR4 were wild type, these are those about 10-ish% Waldenstrom patients who do not carry the MYD88 mutation, well, the response rates were non-existent. This is absolutely important data because this helps get us an insight into we are not just doing these tests because these are long terms, make us sound intelligent, but these do have direct practice patient care implications. And this also goes to telling you that it is extremely important for every single Waldenstrom patient to remember one size cannot and does not fit everybody. Having this information is extremely important to be able to decide what to do with treatments. Okay. Again, I'm kind of probably repeating myself by putting this data out here, but looking at the fact that patients who were MYD88 and CXCR4 wild type did the worse. But I'll take a second to explain that when we look at these survival curves, the more horizontal the curve, the better is the outcome. That is more likelihood that the patient is surviving. And as the curves start dropping down, the outcomes are worse. So mid-88 mutated overall did the best. When you had mid-88 mutation and CXCR4 mutation, both, outcomes go down, the line drifts down. And when you had no mid-88 mutation, then suddenly the outcomes are the worst. Okay, now this is INNOVATE trial. We are talking about ibrutinib rituximab versus rituximab. Again, same idea that when we're talking about mid-88 mutation and CXCR4 wild type, outcomes superior. When you add the CXCR4 mutation, outcomes go down. And now when you go to the mid-88 wild type, the outcomes are different, are lower. Okay. This is talking a little bit different about same data, ibrutinib rituxan versus rituxan, and looking at all these different categories. I don't want to go over all the different categories for both the drugs, but what this is showing is that in all the categories, the ibrutinib rituxan combination was better than rituxan alone. Now, the important part is that studies like this are what have moved forward our understanding and our field significantly, because you can see that if you add an active agent, like in the setting of Waldenstrom BTK inhibitors, you are suddenly seeing the whole of the group improve. Of course, when you compare the whole group, the mid-88 wild types may not have that good of an outcome, for example, but as a whole, everybody is doing better when you're using a better drug. Okay. And then down the road, many new agents are coming up. Ibrutinib was the first one in the group, and then we've had zanubrutinib now approved. Acalabrutinib is another drug that is approved in certain indications. And then tirabrutinib is another agent. And frankly, all of these are being studied. These red dots are talking about what is the inhibition of what kind of proteins. And you will notice that the ibrutinib may be providing a little bit more generalized kind of a suppression, while the other ones are more targeted in their action. In general, in cancers, when the drug is much more tight or targeted to its the particular target it's going after, that means it has less off-target effects, and typically the side effect profiles are better. This is just a general principle. Okay. Now, there are other drugs that are coming up, and they are utilizing, for example, the fact that some of these initial drugs, the monoclonal antibodies like rituximab, obinutuzumab, the BTK inhibitors like ibrutinib, that they can be improved upon. And the group which did not benefit enough with just the BTK inhibitors like ibrutinib was the CXCR4 mutated group. This is a study of a different agent where there is an antibody being brought in to specifically go against the antibody, this ULO drug, which is specifically going after the CXCR4 mutation. So the good part is, now that we understand the genomics, we said, well, the mid-88 positive are going to do good with the BTK inhibitors, for example. But if you have CXCR4 mutation, well, that's where the responses go down. Okay, let's bring in a new drug which can specifically target that. So similarly, these genomics have helped us understand or pick out those groups of patients who do not have the best outcome and what we can do about it. Mavorixafor, another drug, this is going against CXCR4 mutated Waldenstrom specifically, because what it does is it is an antagonist, or it goes against CXCR4. We have used these kind of drugs in some cases where we have had, so for example, when we are using stem cell mobilization for transplant in certain patients, if their stem cells are just too sticky and attached within the bone marrow, a drug in this same family is used to detach the cells and bring them out to the circulation. So similarly, when Waldenstrom cells have CXCR4 mutation, they tend not to be so kind of separated out or be able, they are more in dense aggregates that drugs may not affect them. So these CXCR4 targeting drugs will help open up those aggregates and help drugs get in. And then the second family of drugs, which is not, again, yet FDA approved, is the BCL2 family of proteins, because the BCL2 drugs are very active in chronic lymphocytic leukemia, certain kinds of lymphomas, and now are making their way into Waldenstrom also. The BCL2 family includes 3 different groups called BCLXL, BCL2, and MCL1. So drugs that are targeting these different proteins are being developed. When the BCL2 pathway is inhibited, cell death can be mediated. The first drug that has been studied, and my colleagues in Dana-Farber, Dr. Steve Treon and Jorge Castillo, have published the data on venetoclax, which is being studied in Waldenstrom. And currently there is a study going on of a combination of venetoclax with ibrutinib, because preclinical data has shown that combining a BCL2 inhibitor, venetoclax, with a BTK inhibitor, ibrutinib, augments the ibrutinib's effect. So that phase 2 study of single agent venetoclax has been done and has been presented by Dr. Castillo. And they did look at the results based on whether the patient had been previously treated by an ibrutinib-like drug or not, and whether they had CXCR4 mutations, yes or no. But again, this is a smaller study still, but some very interesting, effective, or very interesting data on the effectiveness. And that's when I said the current study that is going on is by Dana-Farber of the combination of ibrutinib and venetoclax, where the patients are getting ibrutinib, then different doses of venetoclax, and then continuing on ibrutinib and venetoclax. So the treatment is for a total of 2 years, and then the patients are observed. An important thing to point out is, why 2 years? And that's a pretty exciting thing, right? Because otherwise the standard is if somebody goes on ibrutinib or zanubrutinib, they stay on it forever and ever. That's because it seems that the BCL2 inhibitors actually have an ability to affect the disease biology. They don't just inhibit, but actually eliminate the disease. And hopefully that is the reason that we are able to make a change and a change in the disease biology and hopefully provide better disease control. Based on this same concept, we actually had this study just got approved by the NCI and the approval from NCI, FDA, and the CTEP today. This is a study we've written as a part of the National Cooperative Group. I work with what's called the Southwest Oncology Group, SWOG, but this will also be run through the Eastern Cooperative Group, ECOG, and Alliance. These are the large cooperative groups, and this is a federally funded study where half the patients will be given ibrutinib and rituximab, thinking that because this is considered the current standard of care for newly diagnosed Waldenstrom, and the other half will be given ibrutinib rituximab with venetoclax. Patients will be given up to 2 years of treatment, and then they would stop. But the other neat part is that if somebody gets ibrutinib rituximab and they progress, they could actually cross over and the venetoclax could be added. So everybody would end up getting the 3-drug combination if they have disease progression or if they are within the first 2 years of treatment. So the study is just approved as of today, and hopefully now will be getting activated in centers all across the country. And this is another different study that I want to share with you. We shared this data at ASCO, the American Society of Clinical Oncology meeting this year. This is a second generation in the BCL2 inhibitor world, APG-2575, or actually now this drug has a name called lisaftoclax. And what this APG-2575 does is it acts on the same BCL2 pathway, but this drug is structurally a little bit different, and I would say a little bit smarter, that it does not have nearly the similar kind of side effects that have been seen with its predecessor, for example, venetoclax. The data over here is from the 36 patients that were included in the initial study, which had a few patients, 5 Waldenstrom patients, but subsequently, a Waldenstrom specific trial has now been started of APG in combination with other agents. And we have both these studies open at Mayo, the APG alone or APG in combination with other Waldenstrom agents. And the data I have over here is something from CLL. This is just giving you an example from the CLL patient, because CLL, there were a larger number of patients, but I started by saying that the genomics of Waldenstrom are closer to CLL. So drugs that do affect CLL, in essence, some or all of them should work in Waldenstrom also. And this is a patient with very high-risk disease treated with APG-2575, and literally within days of treatment, before even hitting 1 week, their disease burden plummeted and their white count had normalized. We did a repeat bone marrow biopsy, more than 50% had cleared in just a month. We are also understanding that since we talk about MYD88 mutated and CXCR4 mutated, I mentioned that there are several mutations possible in each one of these genes. We are also understanding that there are other kinds of mutations, not the classic MYD88, which we talk about. There are other kinds of mutations that can be seen in MYD88. We are trying to understand and identify them earlier so that drugs can be designed against them well in time. And I won't go into further of these. I think I would like to leave some time for question and answer, but this figure is just showing that there are so many different drugs that are being developed throughout this BTK and NF-kappa B pathway, because now we understand the genomics of Waldenstrom much better. So a quick touch upon how does this affect patient care today. So every Waldenstrom patient should have their MYD88 and preferably also CXCR4 status known. And then depending on whether they have MYD88 mutation positive or negative, CXCR4 mutated or not, mutated or wild type, this WT stands for wild type, the choice of drug should be obtained. And beyond these mutations, the next question that must be taken into account is, what is the speed of response that is needed? How rapidly do we want the response? Are we in a rush to improve? Lots of lymph nodes, hyperviscosity, whatever we're doing, etc. And that's where still, in some places, chemotherapy may have a role. If, let's say, we are trying to get very rapid response, or if somebody has a MYD88 wild type, don't have MYD88, well, chemotherapy options may be needed. There are some things that'll, I guess, my counterparts in subsequent sessions about the treatment will touch upon a little bit more in detail, but we are using these genomics routinely to select the treatments for patients. And similarly, this does not apply only to newly diagnosed, but also to relapsed refractory patients. Picking up whether they are MYD88 mutated or not, CXCR4 wild type or not, responses or treatments are selected. I should point out that there have been a couple of drugs which have shown that CXCR4 mutation status does not really have any impact on those drugs. For example, proteasome inhibitors like carfilzomib. Now that becomes important because what if a patient does not have access to one of the clinical trials, and let's say they are MYD88 mutated, but CXCR4 also mutated. And if we think that at that point, a BTK inhibitor is not working or may not work, well, a proteasome inhibitor-based treatment like carfilzomib-based treatment may work because carfilzomib-based treatment was not impacted by CXCR4 status. So those are important things to know, because not everything has to be done in a clinical trial. Carfilzomib-based treatment is available as standard of care. It's not FDA approved, but is available based on prospective clinical trials. Okay, very briefly, I'll touch upon the fact that as we are doing all of this, we are also depending on the science in the lab to be able to understand how the downstream drug development can happen. And these are some of the tools that, for example, our translation lab over here in Mayo and Jacksonville routinely utilizes. Patients with different patients with Waldenstrom, their disease has been isolated over time, and various cell lines have been developed. And these cell lines have the specific characteristics representative of that patient's disease. And based on that, we have those cell lines available on which we test drugs and test new options. I will just talk about briefly, just put a plug for the fact that over here in Jacksonville, in Mayo Jacksonville, we specialize, for example, in developing digital avatars, so isolating the disease from Waldenstrom patients, understanding the genomics, and then using machine learning tools to identify what biological algorithms may be more pronounced in certain patients versus others. And that helps us figure out how to develop or select treatments. This is not something that we do if a patient walks in through the door. I say, hey, let's do a bone marrow biopsy, let's create a digital avatar, and then let's figure out what drug to use in your case. Right now, I don't think the field of Waldenstrom is sophisticated to be at that point, but I can tell you that this is the way of the future. Waldenstrom, our work so far has made us understand very clearly, Waldenstrom is not just one diagnosis. And in fact, I'll share with you, earlier today, I met a patient for the first time in clinic. And she mentioned that she was diagnosed somewhere else. And without this whole background discussion, the mention was, you've got Waldenstrom, you should be treated with ibrutinib, move on, we'll see you back in a few months or a month or whatever. And the patient's words were that at the time of leaving that appointment, I did not even realize that I had a cancer, let alone the fact, as I mentioned, the easy thing for us is to give a prescription. But the important thing, and that important work, is if I'm able to make my patient understand what they have, make that patient an advocate for themselves, and have that patient participate in their own care, that is what actually makes my life simpler in the long run. Okay, so I'll skip this, but just saying that we isolate cancer cells, we collect data from the genomics, the molecular signature of that, feed that into machine learning algorithms, out comes a digital avatar, and that can down the road lead to clinical and non-clinical validation of drugs. We have developed ibrutinib-resistant Waldenstrom cells as well in the lab, and this has helped figure out treatment options downstream. As I mentioned, even for ibrutinib-resistant models, there is this digital avatar that we use. There are other mutations which are being picked up this way, and so newer drugs that we are bringing forward into clinical trials and hopefully into clinics. So as I mentioned, the main takeaways I'll point out are that better understanding of Waldenstrom biology is shaping our work in drug development and new treatments. Again, one size does not fit all and must not fit all. Newer studies are focusing on how to change the natural history of Waldenstrom and picking up these groups that have been traditionally underperforming, like the CXCR4 mutated or even the MYD88 wild types, and how we can get deeper responses and hopefully fixed duration therapy, not just get on the drug and stay on it forever. And better, more targeted regimens can lead the development of more effective and tolerable agents in Waldenstrom. Thanks a lot for your time, and I believe I'm going to stop sharing my slides so that we can hopefully start going back to questions.
Wonderful. Thanks so much, Dr. Ailawadhi. I do feel as if people have been on all day for all the presentations that have happened so far, they have heard so much and learned so much about mutations. that we're not quite ready to pass our medical boards yet, but you got to start somewhere. I often tell people I got my medical degree on Google because, you know, I've had this for a very long time. So I've had to learn how to find information. And thank goodness the IWMF is such an amazing source of information for all of us. So let's see, what was I supposed to say? We have about 20 minutes, maybe a little bit less, because I think we ran over and we've got a ton of questions to go through. I know some came in the chat and we're probably not going to have time to get to those, but I saw Jeremy mention to most people that those are good questions for the IWMF Connect website or the Facebook group. Those are all options moving forward. So somebody, I think Maureen, you're going to pop the, oh, here's the question, first one. This has been answered earlier today, but we'd like to hear so many different doctors giving us the response to all these different questions. Should all WM patients be tested for both mutations, the MYD88 and the CXCR4?
Correct, yes. Short answer is yes. These are both commercially available, so that nobody should be hearing that, well, we don't have these tests available. There are central labs that can run this. We have samples that come from outside and we run it in Mayo. The way we do it is that we have an algorithm set up. All cases that we are expecting to be Waldenstrom or lymphoplasmacytic lymphoma or somewhere in that group, as I mentioned, the pathologist will look and sometimes they will say, yeah, this does look like Waldenstrom or lymphoplasmacytic, although that may not have been expected before. We will first do the MYD88, and anyone who has MYD88 positive, that sample is sent for reflex testing for CXCR4.
Wonderful. And I have heard, I'm just going to interject this question. I've heard from some people that when they have gone first to a regular oncologist and had that CXCR4 and MYD88 tested, and maybe didn't come out positive, then it's often redone at a major cancer center, and it does come up positive. So do you think there is a disadvantage to having your mutation status checked at somewhere other than a major center?
So I would say, Eileen, the main question that comes up is, well, if somebody's had a bone marrow biopsy, you might as well get it tested. Because as with passing time, there have been improvements in how this testing is done. If somebody has had the testing done and it came back positive, that's good enough. But if it was negative, I think those are specifically the cases where maybe running the test again would be important. Right. Or for example, if MYD88 was tested, CXCR4 was not tested, you may have to do the testing again.
There you go. Okie doke. And this leads right to our next question, which is how important is it to know that status when you're going to be treated with chemotherapy?
So I think I pointed out that in today's day and age, selecting the drugs without knowing this status is not appropriate. So if somebody is, let's say, lymphoplasmacytic lymphoma, MYD88 negative, which is just that 10% or so population, that patient should frankly not be getting the BTK inhibitor, the ibrutinib, because that is where exactly the responses were non-existent.
Right.
That means we are exposing the person to the side effect profile, but are not giving them any chance of benefit. So yes, everybody should know this. Or if you don't know this, seek out someone who can maybe do another biopsy. I'm so sorry to say that you may have to repeat a biopsy, but seek out someone who can do that testing for you.
Yes, that's very clear. Thank you. And the next question, here we go. Can testing for these mutations be done on a blood sample? Some of these questions, I should point out, these questions were all pre-submitted. So people had not heard this presentation when they asked the questions. So that's why some of them will sound as if Dr. Ailawadhi has perhaps already answered them.
Sure. These tests are done on the bone marrow. There are certain tests being developed, quote unquote, liquid biopsies, because that concept exists in a lot of solid tumors. There is something called circulating DNA, etc. But at the moment, these tests are done on the bone marrow.
Thank you. Painful though it is, yes.
I know.
Okay. Next question. I wasn't tested for CXCR4 mutations when I was originally diagnosed, and my bone marrow was biopsied. Should I have it done again now?
So it depends on whether you are getting treatment or not. So for example, if somebody did a bone marrow biopsy and said you had IgM-MGUS, or that you had Waldenstrom or lymphoplasmacytic lymphoma, but you don't need any treatment, then just doing more testing to have that information is not going to make any difference. But if you are to get to the point of requiring treatment, I think at that point, you must get this information handy. So if this can be tested prospectively, great. But if this was not done, I don't want patients to leave today and go around to your doctor and say, hey, can I please have another bone marrow biopsy? I need to know my status. Not necessary. But if you are beginning a new treatment or going to start treatment now, then maybe that testing should be repeated.
Very good. So here are some new words. I don't think we've heard these in your presentation, but the CXCR4 nonsense versus frame shift mutations. Is there any difference between nonsense and frame shift as they relate to BTK inhibitors? Response.
So here's what I would say. We could spend a long time talking about the various kinds of mutations. So there are nonsense, missense, frame shift. And I had just touched upon the fact that the one that I had mentioned, the SS mutation, was the most frequent one seen. When somebody has a gene, there can be mutations in a lot of different ways. Genetic material can be lost. Genetic material can be switched by a point. Genetic material can be translocated, in which some portion is cut out and then it attaches inversely. So a lot of these problems, different problems, are possible. Yes, so there is a difference between frame shift and nonsense, missense mutations. Sometimes there is a genetic material present, but it just doesn't work. I would say for the purpose of our Waldenstrom patients, the testing that you receive as part of your bone marrow biopsy CXCR4 mutation test, it is one term that is given, and that applies to all. So if you have a report and you're given that you carry a CXCR4 mutation, I don't want you to worry about asking, well, was that a frame shift or nonsense? Don't worry about that, because these are all standardized, certified technology. And I would say that for the purpose of our immediate task, CXCR4 mutation is it.
Okie doke. Thank you for that. Okay, this is a big one. As far as overall survival rate is concerned, is it better to have the MYD88 or not?
Okay, so the run-of-the-mill, what we understand, slow-growing, indolent, low-grade, non-Hodgkin lymphoma, now we know that is the MYD88 mutation variety. Those lymphoplasmacytic lymphomas that do not carry the MYD88 mutation tend to be more aggressive, patients would tend to have a shorter survival because, frankly, some of the drugs we have are not effective. Mm-hmm. So I should or shouldn't I have, because that's a part and parcel of the disease and we don't have a control on that. But I can just say that 90% of Waldenstrom is MYD88 mutated. And in the world of Waldenstrom, MYD88 mutation is consistent with the classic diagnosis, which is low-grade, slow-growing non-Hodgkin lymphoma rather than the aggressive kind.
Excellent. Great. Thank you so much for that. And we're still on MYD88. Are there other MYD88 mutations besides the L265P?
Correct. You may remember that one of the later slides towards the end, I had mentioned that other MYD88 mutations, I had a whole list of different ones that are now getting identified and have been identified within the last couple of years by those genetic modelings and algorithms and understanding the genetic sequence. So there are, but currently the MYD88 that we utilize, that 90% having positive, is the L265P. So as of right now, the MID88 is almost synonymous with L265P. What we're trying to understand is that those 10% which or so Waldenstrom patients that do not have this, well, maybe those are the ones that have the different kinds of MID88 mutations, but the 90% of Waldenstrom patients have the L265P.
I think we're going to have to probably wrap this up fairly soon. We have time for probably one or two more questions.
Sure.
So here's one about the false positives, false negatives. Do those come up?
They do, but frankly speaking, that's the question that you were also asking, that the patient may have gotten it tested in the community, it came back negative, they got it tested at the academic center, it came back positive. I'm not going to say that it is not done the right way, but all I can say is that the technology around mutation testing has improved even over the past few years. So if somebody got their MID88 testing done, let's say 4 or 5 years ago, and that was negative, I think it may be reasonable for that individual to think, well, maybe I need to get tested again. The ones who are positive, I don't think that you need to keep testing again, because this test is sensitive enough that the false positive is extremely rare. It just doesn't happen. But false negative can happen depending on the testing type. So if you are negative, at some point you may need to.
Thank you. I do think I'd like to sneak in at least this next one. Maureen, could we go ahead one more slide, please? Are people born with MYD88? I think that's
no. So we're talking about having a genetic mutation. People are not born with Waldenstrom, right? And we had said that, so a lot of different mutations are present. This is a mutation. It is not normal. Mutation is not normal. So, this happens to be present in 90% of Waldenstrom patients.
Excellent.
But in their Waldenstrom cells, in their diseased cells. So if that same individual was to take a swab of their mouth or spit in a tube and run genetic analysis of that, they would not carry this mutation. This is present on the cancer cells, not on the healthy, normal, inherited DNA.
Excellent. Thank you so much. I do feel as if I'm still not ready to pass my Genomics 101 test. And I'm very happy that there's not going to be a quiz after this. But I do feel, as I said in the beginning, that I learn more every time I hear one of these amazing researchers. And I think back to the times after my initial diagnosis in those early days, going to these Waldenstrom's forums and meetings that Dr. Treon would set up, and listening to all the things they were working on, and hearing, in the beginning, what they say, life expectancy, 5 years or something. And here I am 20 plus years later, 25 maybe. So we thank you so much for volunteering. Everybody should know he volunteered his time this afternoon to share all this research with us. And don't worry if it didn't all sink in. Over time, more and more things start to sink in. Of course, then you realize that over time, they're figuring out more and more stuff. So there's just more and more stuff to learn. But fortunately, the IWMF has tremendous resources available for all of us. So huge thanks to all of you who attended. We also need to thank our title sponsors, BeiGene and Pharmacyclics Janssen, as well as Selectar Biosciences, the Treadway Foundation, and X4 Pharmaceuticals. There is another Wednesday set up for next week, so be sure you've signed up for all of those. And then later on in October, 2 more full days that we're all looking forward to. And something new is coming up. We've never done this before. Jeremy Dichter is about to pop on our screen, and he's going to host the first ever IWMF community chat. So he's got a lot of great things planned. And again, thank you so much, Dr. Ailawadhi. This has just been wonderful. Thank you. So we're ready for you, Jeremy.
All right. Hey, everybody. Well, hi. How's it going, Eileen? Good to see you.
Yeah, good to see you as well. Last time I talked to you, though, I don't believe you had that lovely fireplace set up behind
It's
you.
a very fancy office here in
Is it?
Sarasota,
Yeah, yeah,
Florida.
yeah.
Welcome to the
Okay.
home office of the IWMF.
Oh, we can all visit Sarasota and see why you have fireplace.
I promise it doesn't actually. My office looks nothing like this. I'm in Sarasota. I promise. This is my actual office
Okay,
in Sarasota, Florida.
all
Welcome.
right.
My name is Jeremy Dichter. I am your Director of Development and Communications with the IWMF. This is not really what my office looks like either, I promise. This is what my office looks like. And I'm so pleased to see all of you here. So many wonderful people in attendance. I just have to say quickly a huge thank you to Eileen Sullivan and to Dr. Ailawadhi for our most recent presentation. This day has been jam-packed with really, really wonderful and informative content. And I want to remind all of you that this information, these presentations, if you missed any of them, if you want to see them again, maybe you wanted to see a specific part, don't worry, all of these presentations will be made available on demand for you through iwmf.com. So be on the lookout for an email notifying you when those videos are ready to watch. You can also download all of the slide decks and pieces of these presentations through our website as well. So I wanted to get started with our very first community chat. Now, it's been a very long time since many of us have been face to face because of the pandemic and safety concerns. So we wanted to try something to try and bring our community together. And we're doing it the best way we know how through Zoom. So I'm excited to have all of you here. I have a couple questions, and what I'd like to do is kind of have a little dialogue with you. We'll talk back and forth. You can use the chat box to answer some questions, and we'll just get a feel for who's here today. I'd love to share a little bit about myself. Like I said, my name is Jeremy Dichter. I'm the Director of Development and Communications with the IWMF. I've been with you since 2017. And this is my, oh gosh, is this my fourth? I think this is my fourth Ed Forum. And it's changed every year. We've certainly grown a lot. And I hope you got a kick out of the information you learned today. And I hope that you have signed up for the next few sessions that we have next Wednesday, like Eileen said, and at the end of the month. So just to get to know everybody here, I thought it'd be fun if we went ahead and, let me see if I can get my screen to share. Let's see. I want to share my screen so you can see my little slide deck. There we go. Perfect. All right. So hopefully that popped up for you. The first question is, how many years ago were you diagnosed? For the people in this room, I know we have folks who have been here and have been diagnosed. Let's try raising our hands. There's a little button in the bottom of your Zoom area. You can raise your hand and tell us how many people here are newly diagnosed. You've been here. This is your first Ed Forum. You're newly diagnosed with WM. Go ahead and raise your hand for me. All right, I see the folks, I see the number going up. I'm not sure if you can see it on your end. I'm seeing 26, 27, quite a few folks raising their hands that this is their very first Ed Forum and that they are newly diagnosed. And I also see in our chat, we have folks on here 1 month, 3 months. Excellent. Well, this is your first stop on your WM journey. I hope so far this day has been informative for you. Please know that there is a wealth of information and resources available for through our website, iwmf.com, for anybody who's newly diagnosed. In fact, there's a landing page just for newly diagnosed folks. I hope you can navigate there and get connected. All right, so how about, go ahead and put your hands down. How about people that have been diagnosed maybe 2 to 5 years? Well, this is so neat. I don't know if you can see it on your end, but we had roughly 27 newly diagnosed people. I'm seeing about 20 or so, 25 folks who've been diagnosed between 1 and 5 years. How about you go ahead and put your hands down? How about folks that have been diagnosed maybe 6 to 10 years? Wow. 21, 22, 23 participants, 26. Wow, the number is climbing there. So for you newly diagnosed folks, it's certainly nice to see folks here that have been living with WM for 10 years. How about our 10 to 15 years? Is there anybody who's 10 to 15 years? Wow, look at that. And this is remarkable. When the IWMF started, Arnie Smokler, a retired pharmacist, came to Sarasota, and he was diagnosed with Waldenstrom's macroglobulinemia. And the average life expectancy of somebody from diagnosis was maybe 5 or 6 years at the time. We now see folks living with WM for, gosh, look at this. 15 folks in here that are 10 to 15 years. How about 15 to 20? Do we have anybody who are 15 to 20 years in here? Wow, look at that. Look at that. That's just wonderful. Wonderful. Five people in this room are 15 to 20 years. Now I'll just do one last one because I'm just curious. Is there anybody who's 20 years plus? Anybody here for 20 years? 20 years plus. Wow. 6 people in this room, which is pretty phenomenal. So advancements in research and treatment options have really made a huge difference for folks with WM, and we can see it here in this room. Well, I really appreciate you sharing that with us and participating. I want to go ahead and move on to another question. Where in the world are you from? Where are you coming in from? I know earlier folks were saying hello. I'm just curious if we have folks, what countries are folks coming in from? Excellent. Yeah, we've got people all over the place. And go ahead and open up your chat box if you haven't already, and you can see the responses from everybody as they're piling in. Wow, South Africa, Sweden. Excellent. There you go. Wow. We are Canada. Excellent. Quite a few folks here coming in from all over the place. This is just really, really wonderful. I think at our last educational forum, our last virtual forum, we had over 1,500 attendees from over 34 different countries. So this really is a global WM community. Wow, there we go, from Germany. Excellent. Excellent. Look at all this. Wow, Brazil, fantastic. So good to see everybody here. This is great. We like I said, we have WMers all over the world. If you haven't connected already with your local support group or with your international affiliate, folks, please visit our website and get connected with folks in your area. There's a really strong IWMF community out there, and we want to get you connected. So be sure to check out the website. Speaking of, have you attended, why don't we raise our hand, how many folks in this room have attended a WM support group before through the IWMF? All right. That's a ton of people. I'm not sure if you can see it on your end, about 53 people here have attended before. Oh, the Facebook support group. Yeah, we don't want to forget about that one. Sharon, I see you there. We have one in Sarasota. You're in our hometown. It's good to see you. Wonderful. Now we do have Meg. Meg is our Facebook moderator, and she is absolutely phenomenal. Definitely join us next Wednesday, where she'll be moderating one of our sessions and doing a Q&A. If you have any Facebook related questions, man, you have to check out our Facebook page. Meg just does a lovely job. Meg is the bomb. Thank you for that, Mary. That is very true. Love Meg. I hope she can hear it if Meg's on with us. We certainly appreciate you. Well, good. I'm so glad so many of you attended a support group before. I want to go ahead and, speaking of support groups, I want to go ahead and do what we're calling our IWMF Community Member Spotlight. We reached out to WM patients and caregivers across the globe, and a few of you sent in some videos introducing yourselves and telling us how you're connected with the IWMF. So I just want to go ahead and share our community spotlight on Judy Francis. And hopefully I'm sharing my audio with you too. So give me just 1 second. It's always fun when you're, here we go, share sound. There we go. All right. And let me know if you can see this in the...
Hello, I'm Judy Francis with the Dallas, Texas Waldenstrom Support Group. And what the IWMF means to me is a great source for information, accurate information, and up-to-date information about Waldenstroms. In 2006, when I was diagnosed, there was really very few places to turn for information. And of course, everybody knows going to the internet will take you down a rabbit hole, and before you know it, you'll be dead. So, going and getting accurate and concise information is very valuable. And that's what I think the IWMF offers, is a place for people to go to get the information they need, to get the answers they need. We're in a support group, and if you join a support group, you'll make new friends, and you'll be able to discuss your issues that you have with Waldenstrom's. The IWMF pulls all that together. The people up there are so nice, and if you get to know them, you just automatically feel like you're friends with them. So take my advice, go out to the website, search the internet with the IWMF website, get involved. They're there to support you. They are up to date with all the new emerging treatments and technologies and happenings in the WM world. So use their resources. They're just invaluable. And everybody, just have a good time at the forum. Good. Thank you for the time that you've taken listening to Mwa. Talk to you later. Bye. Hello, I'm Judy Francis with...
All right, folks, can you hear me okay? Hopefully I'm back. There we go. Awesome. And let me go ahead. I'm going to pull up my slide deck again. We have a couple more questions if you're interested in continuing our chat. Give me just a moment here. Alrighty. And let me share my screen again. Awesome. All right, hopefully I did it right. Okay. So have any of you attended an IWMF Global Educational webinar before? So throughout the past year, we've been, oh, perfect. I see everybody raising their hands. We had a series of educational webinars that we put out from a variety of different institutions with different speakers. If you haven't had a chance to check them out yet, oh, I'm seeing so many people that have watched our global educational webinars. That is just wonderful to hear. 37, 4, oh, this is just great. So if you haven't had a chance to check them out, there's a variety of different topics that we've covered. And again, all of this information is available on iwmf.com. But we'd love to hear more from you. You know, we do various educational webinars, and if there's a topic that you're interested in that we haven't covered before, we'd love to hear from you. And a great place to do that is, of course, feel free to email me directly at jdictor, DICTOR at iwmf.com, or go ahead and connect with us on IWMF Connect by visiting our website. It's a great place not only to interact with the other members of the WM community, but with the staff and volunteers here at the IWMF. All right, so I'm so happy to see we had so many people that have attended those webinars. Just a few other questions that we could go ahead and go through. You know, maybe something good that has happened to you in your life since you were diagnosed. People have been WM for 20 plus years. What are some good things, some things that you've looked forward to, things that have happened to you since your WM diagnosis that you're happy about? You go ahead and type in those responses if you want, if there's something you'd like to share. You've met so many amazing people. Mel Horowitz is one of our volunteers and support group leaders. Mel, you are a wonderful person. You are an amazing person, and we're so happy to have you here. Carl Harrington, met many new friends around the world. Absolutely. Everything you've learned, this is fantastic. Excellent. I realize that I'm tougher than I imagined. That's pretty strong. That's pretty strong. You know, in our IWMF annual report, if you've had the opportunity to check this out yet, we interviewed a WM community member who shared a similar sentiment to you, Mary, that, you know, he felt that, you know, some of the best years of his life happened after he was diagnosed with WM, which I thought was a very interesting perspective. If you haven't had the opportunity yet, you can check out the IWMF annual report on our website as well, and actually through the IWMF events page where you all logged in. It's a great resource. How about one of the questions that you still have about WM? Are there questions out there that you haven't had answered yet? I know that folks were typing things in during Dr. Ailawadhi's presentation. You know, save those questions. If there's something burning that hasn't been addressed yet, we want to make sure that we get you all the information that you need. And you feel free to put your questions in here. We'll collect all of them. And we would love to be able to address them at a later date. Also, and I'll keep saying it only because it is such a wonderful resource, but IWMF Connect is a wonderful way to get connected with other folks in our community and start a dialogue, go back and forth. If you have questions about a specific treatment, there's also our IWMF phone lines, which you can call with any questions you have. We'll be happy to get you connected with the appropriate resources. I have another IWMF community member spotlight that I'd like to shine on, and that's on our dear friend Anita Lawson, who I think you'll all love to hear from. If you give me just one moment, I'll go ahead and share it.
Hi, everybody. This is Anita Lawson. I am the co-leader of the South Florida Support Group, and I've been associated with the IWMF for many years because I've been a patient for many years. And I was, diagnosed almost 18 years ago. I can tell you all that the IWMF is a marvelous organization, and it's composed of all kinds of staff and volunteers and patients and families, and they're a wonderful, caring, smart, dedicated group of people. And if you come to the Ed Forum, which I strongly encourage, you will get to meet some of them.
Excellent. So that was Anita Lawson. And she is a wonderful support group leader in South Florida. I'm sure many of you on the call might have attended her support group before. Go ahead and pull back up my screen. Hopefully you can see it. Okay, so are you registered to attend the rest of Ed Forum month? What session are you most looking forward to? I see Suzanne raised her hand. We have a lot of folks raising their hands. Oh, you're raising your hands to tell me that you've registered for the rest of the month. I got it. Totally perfect. That's great. So many people. Okay. Bettina's looking forward to a session on peripheral neuropathy. Excellent. Yeah, it's a very requested topic that we have, and there's actually some great resources again on our website. You can check it out. We have some pre-recorded videos about peripheral neuropathy as well. Ask the Doctor panel, always the best. I agree, Lisa. Well, although I really liked your session this morning, Lisa, but I am also looking forward to Ask the Doctor. It's going to be a lot of fun. Yeah, our rock star doctors, that Q&A panel. Don't forget to register. If you haven't done it yet, folks, there's still time to do it. Our Q&A panel is going to be the closing of our Ed Forum on the 29th. It is not something you want to miss. We have just an awesome panel of doctors with Dr. Stephen Treon of the Dana-Farber Cancer Institute, who will be running that session. So we are very excited. Excellent. Good. I see some. Oh, yep. WM in the eyes. Absolutely. That's another one that we've received quite a few questions about. That's exciting. Okay, let's move on to another question. One of the things I do to help me cope with my WM diagnosis is what? So many of us have different coping mechanisms and ways that we deal with our WM. Maybe you have some advice, some things that you'd like to share with us. You're welcome to go ahead and put it in the box. It's yeah. Oh, thank you so much, Eileen. I think Eileen is trying to, oh, perfect. There we go. Eileen has just shared with us in the chat box a link to sign up for IWMF Connect, which is fantastic. Excellent. Oh, yoga and acupuncture. That's helping you cope with your WM. That's fantastic. Lisa Wise says writing. I love it. I love that. Paula says crochet to relax and wind down. Nothing like it. I have to tell, I don't crochet, but I imagine it's a very relaxing activity. Yoga and meditation from Sharon. Wonderful. Yeah, I play guitar. I like to sit out by my pool and play guitar. That's my method of relaxation. Guided meditations. Very nice. I like that. Yeah, there's a ton of stuff on YouTube. That's a great one. Road biking. Sharon says biking. That's wonderful. I wonder, Sharon, do you do the Legacy Trail here in Sarasota? Oh, good. Yes, we have a link to our Facebook page as well. Yes, thank you, Meg, for sharing that with us. I hope you heard, Meg, everybody saying such nice things about you earlier, because we love you. Oh, okay. Hank says music, journaling, and prayer. Yeah, that is great. Knowledge is the key. I couldn't agree more. Wonderful. Yeah, and that's part of it too, right? We have these different things that we can coping with something is learning from it. I really liked what Dr. Ailawadhi was saying earlier about participating in your own care, which I think is so important and something that so many of you are really you're taking those steps to do that by being part of this educational forum. You're becoming as informed a patient as you can be, and that's such an important thing to do, especially with a rare disease like WM. Learn as much as I can about genetics and treatment. Yeah, that's excellent, Paul. Mel says, I appreciate being on the WM talk list, which enables me to give back by speaking with WMers from around the US and the world. Yeah, the talk list is wonderful. It's a great resource for our community. Let's go ahead. We'll move on to another question. My diagnosis has changed my family dynamics. In what ways? Maybe there's some familial WM. Maybe your diagnosis isn't something that you shared with your family. Our diagnosis impacts us all differently, and hope you know about oh yes, oh thank you, Holly. Yeah, our weekly yoga sessions are absolutely wonderful. Please, if you haven't signed up for it, definitely check it out. It's been a highlight for our community. I know a lot of people are enjoying that. Eileen, that's my primary care doc says that she thinks I'm still here because I'm a good self-advocate after 25 years. Thank you for that, Eileen. Yeah, that's why what Dr. Ailawadhi said was really was resonating with me. I think it's so important to be to be informed. Okay, I didn't share my diagnosis with my parents. Yeah, that's learning about WM helped me be a better caregiver to my husband, who had another kind of blood cancer. So some of us are not only patients, but we're also caregivers or care partners for others. Yeah. Full-time caregiver. Excellent. Wow. Leah says, I no longer am anxious about my WM because of the IWMF people and education. That's really wonderful. Oh, more isolation, Joanne. That's a really good point. Yeah, having to stay away from folks in your family because of your because of being immunocompromised. Yeah. I think Holly says, I think WM has been a good example to my family about being a strong self-advocate. Excellent, excellent stuff. Tigra says, oh, you're okay. So your father died 12 years ago tomorrow. I'm so sorry to hear that, Tigra. Well, hopefully, as they were discussing MGUS and some of the underlying pieces here, that you have a little more information about it now. And again, please don't hesitate to connect with us through our website. We'd love to get you the support you need. Yeah, we have a strong support community here, which is great. You know, sometimes it's just so nice to connect with somebody else who's going through the same thing as you. Although, you know, I enjoyed what Lisa said this morning. I think she was quoting Pete Donardis, but that when you've met one WM patient, you've met one WM patient, because of course we know everybody's symptoms are different, and everybody experiences this disease in a slightly different way. So getting connected with other folks is so essential. The hardest thing so far about living with WM, what would maybe share some of the difficulties that you've had, if you feel comfortable. I know that for many, you know, maybe the fatigue is a difficult piece. Knowing that it's chronic, yeah. Being immunocompromised during a deadly pandemic, yeah. You know, this is something that comes up all the time. Particularly, of course, difficult for our community right now. I'm seeing lots of messages coming in. Yeah. Oh, Mike says no specialists in South Africa. Well, let's Mike, go ahead and you can message me your contact info, and I will I'll do my best to get you connected with anyone that we can. Going from fully functional to using a walker. Yeah. WM will always be with me. Yeah, it is it is incredibly difficult living with something that is currently incurable. But fortunately, you know, we have great news coming out all the time. WM research right now is just mind-bogglingly complex in some ways. But I hope that for those of you who you know, have a difficult time thinking of WM and living with something that will always be with you, there are so many bright spots on the horizon for WM research, and I have to say, stick with us throughout the rest of the Ed Forum. There's some really great information that we want to share with you. I know that we'll be discussing IWMF LLS funded WM research in our very last session during the Ask the Doctors panel, and that's something you really won't want to miss. It's exciting things. Okay, quick question. Go ahead and raise your hand. I think it'll be easier to do it that way. Let's raise your hand if you are a caregiver that is attending today's chat. Excellent. Okay, we have a couple folks. And then go ahead and put your hands down. And then how many of you here are folks that are WM patients yourselves? Okay, so about half the attendees, possibly more. Okay, great. Excellent. Yeah, it's such an interesting mix of attendees here. I'm sure we also have you know, we say caregivers, care partners, and patients. Of course, you know, there are, you know, family members here. There are other medical professionals. I like to think if you're outside of being a patient in many ways, you know, you are a caregiver. If you're here and you're learning about WM, you count in that first group for sure. Okay, and one more question for us. One of Oh, sorry, there's a spelling error on here. You'll forgive me. But one of the reasons I come to support group meetings is what? There's a million reasons to come, I'm sure. And in fact, I'd actually like to try something, if at all possible. I should be able to invite somebody to come up and speak. You don't have to come up on camera, I don't think. But if there's somebody who would like to share a personal reason why they attend support groups, or why perhaps they run a support group, go ahead and raise your hand, and I guess I'd be happy to call on you. We can give it a shot. Why not? We'll try something new. All right, Hank. Hey, Hank, can you hear me? No? Let's give it a try. Anybody want to share their experience with IWMF support groups? I see some great messages coming through. Okay, I have somebody who's raised their hand. Sharon, let's give Sharon a shot. Let's see. Sharon, can you hear me? Let me see. It looks like I've given you permission to talk, Sharon. Let's see if it works. Let's see. Might not work. That's okay. Okay, let's try Brenda Rogers. Brenda, go ahead and unmute yourself. Are you there, Brenda?
Hi, I'm here.
Hey, Brenda, where are you calling in from?
Hi, you can't see me though, right?
No, I can't. Please, if anybody can see you, please let us know. I don't think so. It should just be audio.
There's no video.
Good, there you go. You got to make sure these days. Where are you calling in from, Brenda?
I'm from one of the Canadians, calling in from British Columbia.
Happy to have you with us.
On the West Coast, thanks. And I'm one of the support group facilitators. And I really like our group because during COVID, we were forced to not meet in person, which is obviously preferred. Sure. But just because of the geography of how where we're located and people living in different areas of British Columbia, it was kind of tricky. So we switched over to Zoom and had the continuity and consistency of meeting each month, which to some people that they could be horrified if they're meeting monthly. But sure. Our group is a really fun, friendly, open, honest group. And we're a group of people that are celebrating just living and being, having a diagnosis. So we do check-ins of like, how are you with your family? How was that vacation? How was that, the grandchildren doing? As well as how are you doing? Like, how was that doctor's appointment? So it's a little bit more of a holistic take, which I think helps people come back. And then also there's definitely, you're not alone. And by being on Zoom, we can have people from all over British Columbia, because it's a large province, meeting and getting to know other people so that they know they're not alone with some people have difficult diagnosis and circumstances, and just to know that they're not alone, and helping give people, not that we give advice, but just like, these are the questions you may want to be asking your doctor or the oncologist, or try asking this or doing that, or I had this. And other people go to a lot of the webinars and share little tidbits with all the group that might not have been able to do it. And I got good reviews from those who are on the peripheral neuropathy support group. They took that back to our support group and kind of just did a little condensed version, so that other people still got to have the benefits of it. So,
oh, I love that. That is just so wonderful, Brenda. Brenda, thank you so much, and thank you for volunteering, not only to be, of course, a support group leader, but also volunteering to come up and speak and potentially be on camera, which you're not. But
well, I'm ready for the camera. I just have no video. But anyways, yeah. Hello to the fellow Canadians, and if there's anybody in BC that wants to join our group, please reach out.
There we go.
To the WMFC, right? That's the Canadian branch of the IWMF.
That's correct. And you can see a listing of all of our support groups and international affiliate contacts by visiting iwmf.com to get connected. Or of course, if you're in BC, WMFC is the website to visit. Excellent. Does anybody else want to come up and don't be too shy, but you're welcome to come up and share a little bit about your experience, maybe as a support group leader, maybe if there are any caregivers on here who'd like to speak up and share their thoughts. Perfect. So let me go ahead and close this out. See if I can pop up on the screen here. Stop sharing. There we are. All righty. I am back. Wonderful. Well, that concludes our community chat. We don't have any other questions to pose to the community, but I want to thank all of you so much for being here. This was just an absolute thrill. Thanks for being part of something new. If you enjoyed this session, if you enjoyed doing our community chat, join us next Wednesday afternoon, for a whole new set of questions and hopefully a whole new group of people to connect with, as well as a wonderful, wonderful day of learning and resources from the IWMF. I want to do one quick plug. If you haven't had an opportunity yet, please check out the Walk for Waldenstroms. It's all over our website. You can't miss it, but it is a virtual 5K fundraising and awareness building campaign for WM. If you're not signed up yet, it's super easy. It's a great way to raise awareness of this very rare disease, and also to raise some money for excellent programs like the one that you're participating in right now. So check out our Mighty Cause fundraising page, and you can see all of this again by visiting iwmf.com. So on that note, I want to thank all of you one last time. Eileen, if you're still here, Eileen, thank you so much for moderating today. I know Dr. Ailawadhi already had to hop off, but for everybody else, our board of trustees, and of course, our partners, our sponsors, our title sponsors, Beijing, Pharmacyclics Janssen, and Selectar Biosciences, the Treadway Foundation, and X4 Pharmaceuticals. On behalf of the entire IWMF community, thank you so much for joining us today, and I look forward to seeing you next time. Take care, everybody.